Welcome to this explainer. Today we are diving into a really fascinating, highly structured diagnostic decision tree, the clinical management of hyperthyroidism and goiter types. Now, in actual clinical practice, managing the thyroid isn't about guesswork, it's not trial and error, it's a highly systematic process of elimination. It's like a giant puzzle. Before prescribing even a single pill, doctors have to parse through intersecting symptoms and completely distinct biological mechanisms just to find the precise root of the issue. So let's break down the exact logic and flow physicians use to navigate these conditions step by step so we can really see the architecture of medical decision-making in action. Here is our roadmap for today. We'll kick things off by separating brain versus thyroid causes. Then, we'll move into subclinical cases, where, believe it or not, no treatment is needed. Tackle the painful exception of subacute thyroiditis, outline the standard protocol for other peripheral causes, and finally, look at surgery and radioiodine as absolute last resorts. All right, part 1, brain versus thyroid causes, or finding the source. We have to start at the very top of the decision tree to answer the most critical first question. Where is the problem actually originating? If the cause is central, meaning the source of the hyperthyroidism is located all the way up in the brain, the medical tree gives a definitive, immediate answer. The treatment is surgery. Central causes are usually TSH-secreting pituitary adenomas. And the thing is, these adenomas don't just mess with your hormone levels, they can cause a massive structural threat in the brain. We call this a mass effect, which leads to complications like severe headaches or bitemporal hemianopsia, which is a very specific type of vision loss. Because of this physical danger, neurosurgery is the definitive intervention. But if the cause is peripheral, meaning the problem is rooted right there in the thyroid gland itself, the path forward requires a bit more navigation. For peripheral issues, the treatment has to be delineated by the specific symptoms the patient is presenting with, which opens up a whole new set of diagnostic branches for us to explore. Moving right along to Section 2, subclinical conditions, where no treatment is needed. So heading down that peripheral path, we hit our next major fork in the road, checking whether the patient actually feels sick. You know, it takes some real clinical discipline for a doctor to not immediately prescribe a medication just because a lab value is slightly off. If a patient has a peripheral thyroid problem but they are completely asymptomatic, they fall into the subclinical category, and an asymptomatic peripheral thyroid condition requires absolutely zero active treatment. The protocol here is strictly follow-up. Now, you might be wondering, why do we just watch and wait? Well, it's because the risks of antithyroid medications, which can actually include liver toxicity and this really dangerous drop in white blood cells known as agranulocytosis, often outweigh any potential benefits in someone who doesn't even feel sick. Plus, a lot of these subclinical cases either spontaneously normalize on their own over time, or they simply never progress to overt disease. In these scenarios, watchful waiting isn't just doing nothing, it's the active gold standard choice. Okay, part 3, subacute thyroiditis, the painful exception. Now, if the patient is no longer asymptomatic and is displaying clear, overt symptoms, the decision tree immediately looks for one very specific, flashing red flag: pain. Subacute thyroiditis is the absolute only thyroid condition that actually causes a painful thyroid. No other one does this. This happens because subacute thyroiditis is typically a post-viral inflammatory process. Basically, the inflammation causes rapid swelling and stretching of the thyroid capsule, and because that capsule is heavily innervated with nerves, it results in a distinctly tender and painful neck. If a symptomatic patient presents with a painful thyroid, boom, the algorithm immediately isolates a diagnosis, separating subacute thyroiditis from literally every other peripheral cause purely based on this one defining characteristic. Because this specific, painful condition is self-limiting, meaning the viral inflammation will eventually just run its course and burn itself out, the goal isn't to aggressively attack the thyroid's function. We're just playing defense. The medical approach is entirely supportive. The doctor prescribes painkillers, specifically NSAIDs, to manage the inflammation, and might even step up to steroids for the really severe cases. But notice what is conspicuously missing here: antithyroid drugs. Why on earth wouldn't we use standard synthesis inhibitors like carbimazole? Well, the brilliant clinical insight here is that the hyperthyroidism in subacute thyroiditis isn't caused by the gland overproducing new hormones. Instead, it is caused by the release of already preformed thyroid hormone just leaking out of the follicles that are being destroyed by the inflammation. It's like a warehouse leaking inventory, not a factory running in overdrive. Because the gland isn't synthesizing new hormone, synthesis inhibitors would be completely useless. You just manage the inflammation, you manage the pain, and you schedule a follow-up as those preformed hormones wash out of the patient's system. Which brings us to Section 4, treating other peripheral causes, or what we can call the standard protocol. So what happens when this symptomatic peripheral problem isn't subacute thyroiditis? Well, we have three distinct diagnoses that fall into this non-painful overt category: Graves' disease, toxic multinodular goiter, and toxic adenoma. Despite being entirely different pathophysiological conditions, they all funnel into the exact same first-line medical response. The primary line of attack is an antithyroid drug, specifically carbimazole, which works to block the synthesis of new thyroid hormone, shutting down the factory, so to speak. But there's a major catch here, and it perfectly explains the strict 4 to 6 week follow-up cycle. Carbimazole stops the gland from making new hormone, but it does absolutely nothing to the hormone that is already stored up in the thyroid gland's colloid. It takes roughly 4 to 6 weeks for the body to naturally deplete that stored colloid. Because of this massive delay in clinical response, patients are immediately put on beta blockers, specifically propranolol, to control the dangerous cardiovascular symptoms, like tachycardia and heart palpitations, while they wait for the carbimazole to actually take effect on the body's circulating hormone levels. Finally, Section 5. Surgery and radioiodine treatments. This is all about escalation and last resorts. As we all know, medical protocols don't always work perfectly, and this decision tree has strict escalation points built right in. If a patient hits any of these specific criteria, they are immediately rerouted away from medication and straight into surgery. First, if a patient has a really big goiter that is physically compressing the trachea, they might experience dysphagia, which is difficulty swallowing, or stridor, a high-pitched wheezing sound caused by disrupted airflow. These are urgent mechanical issues. And listen, you can't fix a mechanical compression with a chemical pill. You just can't. It demands surgery. Second, if a patient has a recurrent disease that just keeps coming back after cycles of medication, definitive surgical removal is indicated. And third, if the patient simply is not responding to the medical treatments we outlined earlier, the physician has to abandon the medical route and move straight to surgery to resolve the hyperthyroidism for good. So, that leaves us with one final dramatic intervention on our medical roadmap. We've talked about medication, we've talked about waiting, and we've talked about surgery. But when is radioiodine actually deployed? Radioiodine is truly the absolute last resort in this clinical algorithm. It's used only in two extreme scenarios: if the patient actually has thyroid cancer, or when surgery is required but simply cannot be performed because it carries way too high of a surgical or anesthetic risk for that specific patient. Why is it kept as a last resort? Because administering radioiodine permanently and irreversibly destroys the thyroid gland. It just wipes it out. This guarantees that the patient will develop lifelong hypothyroidism, meaning they will be permanently tethered to levothyroxine replacement therapy for the rest of their life. On top of that, it carries really strict radiation precautions, where patients actually have to physically isolate from their family members for a bit. And it has hard contraindications, too. For instance, it absolutely cannot be used in pregnant patients, and it can severely worsen Graves' ophthalmopathy, which is that bulging eye condition you see in some hyperthyroid patients. Because of these intense, life-altering clinical consequences, it remains the ultimate fallback option. All right, we've now traced the entire logic of this disease, from the brain all the way down to the absolute last resort. I want to leave you with a challenge. If you had to navigate this decision tree today, could you confidently route a patient from diagnosis to cure without getting lost in the branches? Keep that central versus peripheral split in your mind. Remember the vital diagnostic role of pain as a clinical marker, and really know your firm's surgical escalations. Thanks for joining me for this explainer, and I'll see you next time.